Through studies, it has been found that the risk of developing AF doubles with each progressing decade. Atrial fibrillation, AF, is the most common heart rhythm disorder and affects millions worldwide. In Singapore itself, 0.5 to 1% of our population has AF, with prevalence of the condition increasing with age. So today, to tell us more about the association with AF and age, we have Dr. Lim Tun Wei, Senior Consultant Cardiologist at the National University Heart Centre Singapore. Dr. Lim will be sharing his expertise on the connection between aging and AF, a prevalent heart conditions. If you have any questions regarding cardiac health, please raise your hands during the Q&A session later. So without further ado, may I invite Dr. Lim. Dr. Lim, please.
Thank you. Thank you. So I can use either mic, I guess, huh?
Yeah, you can use either mic.
Okay, thanks very much, Terence, for the kind introduction. You already gave a lot of very important statistics. Maybe I don't need to talk so much, huh? Okay, so I was asked to talk about how does older age increase the risk of atrial fibrillation. And it's a good topic because we are finding that AF is now becoming more and more common with the aging population. And I guess by the fact that so many of you have taken time off to join us on the weekend means that it's an important topic and there's a lot of interest for that. So I will start from the basics. We'll talk about what is AF. Okay, so in a normal heart, there is a timer, like a pacer, in your heart called the SA node, which is, okay, does this work? Not too well. Okay, the sinoatrial node you see in the top left. And that will fire rhythmically every 60 to 80 times per minute. And from there, the electrical signal will flow from the sinoatrial node through the atrium, which then progresses through the AV node. This is like a gatekeeper for conduction of electricity into the ventricles, which is really the pumping chamber of your heart. And that is one heartbeat, right? And this heartbeat is what we capture on the ECG, and each part of that cycle is captured as a spike on the ECG. And the ECG is a very, very key thing because that will tell you what the heart rhythm is, and it's also the first way we use to diagnose atrial fibrillation. So in contrast to that, with atrial fibrillation, there is chaotic electrical activity within the atria. The right atrium and left atrium, as you can see on that, I'm just using these arrows to show how it's kind of really chaotic. There's no organization to it as far as we can tell. And it is, in fact, the most common clinically significant heart rhythm disorder. And as Terence mentioned, is increasingly common with old age, more than 10% perhaps in the age over 80. You mentioned about 0.5 to 1% of the population. That was based on the Singapore longitudinal aging study, where a bunch of, I think, medical students went to blocks of flats and looked for people over 55 who were well, no problems. And even then, 0.5 to 1% had AF when we did an ECG on them. So it is actually quite common, and all these people didn't know they have atrial fibrillation. Often the symptoms are mild, or maybe even no symptoms, and that's why a lot of times it's not detected. And the easiest way and most common way is actually an ECG is how we do that. But the worst thing is sometimes the first time people know about it is when they have a stroke. And that is because AF increases your risk of stroke by up to 5 times. And your risk per se actually varies greatly depending on your other risk factors, and we'll talk about that later. The problem with strokes from AF is that they're often a lot more serious because of the mechanism how it's caused. There's usually more likely to cause deaths, more likely to cause disabilities, more likely to cause nursing home admissions after a stroke than a stroke that is not due to AF. And the reason for that is I've got a video here to show you. So in this video, you see that the fibrillating thing, the thing that's quivering on top, that is the atrium. And instead of pumping rhythmically, it is basically fibrillating or quivering. As a result, the blood flow is a little bit sluggish, and so there's time for the blood cells to clump together and form blood clots. And these blood clots, if they break off from the left atrium, they would enter the circulation. And you might not know this, but the brain takes about 20% of your blood flow from the heart, and so it's most likely to head there. And this blood clot will travel down the arteries in your brain, and eventually it will go into a branch where it will get wedged and block the artery completely. And once that happens, you will lose blood supply to that part of the brain, and no more oxygen going to that part of the brain means that the brain tissues there will die, and that is what a stroke is. So the reason this is more severe in AF is that for the other kinds of strokes, usually the blood clots will come from your neck arteries or from the small arteries in your brain, so they're tiny clots and they'll block a small vessel. Coming from the heart, the clots can be very large. Could be even half a centimeter is huge and will block off half your brain, and that's why it often causes very severe strokes. So now that's the scary part past. We'll talk about why it's a problem. And prevalence of AF is growing in Asia. It's all over the world. Prevalence means in a population what percentage of people have AF, okay, the total number. On the left panel is the US data. And as you can see, they project by 2050 that there will be probably about 7 million people in the US with AF. That's a pretty big number. On the right-hand panel is more East Asian data. And the top line is South Korea, the red line is Taiwan. And they estimate it to be between 4 to 5% of the population by the time they get to 2050. So Taiwan and South Korea are going through the same demographic change as us, rapidly aging population. You might have heard, any guesses how many people in Singapore, what's the percentage of people in Singapore will be over the age of 65 by 2050? Have you heard this number? 1 to 4 is 2030. 1/2. Yeah, I'll be in part of it. Half the population will be over 65, all right? So I'll be there too. So that's a big factor of that. And you'll see why, because if this is US data again, and you can see that if you're down in the left-hand side, below 55 years old, your rate of AF is like 0.2 to 0.1%. 0.1, 0.2% of the population under 55, which is about right. But as you get up to the 85 age group, you see it's like 9 to 11%. So men get it more than women, but in terms of the number of patients altogether, it's actually equal number of men and women with AF because women live longer, okay? So men get it more frequently, but because there's fewer men over the age of 85, there's actually about the same number of men and women who get it. What about East Asian data? So this is quite a recent paper I just found from China. And they divided into men and women. Men is the salmon-colored ones. The women are the blue ones, blue columns. And you'll see that it's about 5 to 6% in people over the age of 80. The bottom two ones is kind of interesting. I'm not really sure why. Urban areas is slightly higher than rural areas in China in terms of AF rates. Again, above the 80, you see that you hit rates of 6% in the city, which is probably more like us, and in the country areas, it's about 4 to 5%. What about Singapore? So this is a paper I did with some of my colleagues in NUH, where we looked at the Ministry of Health data. And what we found is that so we looked at data from 2008, which is on the left-hand side, to 2015. The left-hand panel is for people between the age of 45 to 64. The right-hand panel is for the people above the age of 65. And what we found is that there's an increasing prevalence over time. As you can see, the lines gradually go upwards, yeah? The blue lines. And what's the absolute number? So if you're 45 to 64 years old, the rate of AF is about 0.8%. Shockingly, 11 to 14% of these people will be dead within 1 year, okay? If you're over 65 and you have AF diagnosed, this is newly diagnosed AF, take one step. So 6 to 7% of people over the age of 65 have AF, and of these, about a quarter, maybe even up to nearly a third will be dead within a year. Pretty shocking statistic. It's not that AF kills you necessarily, but AF is a marker that things are wrong. So these are mostly patients who are admitted to hospital and they were newly diagnosed with AF, so they probably were quite ill to start with. But nonetheless, it means that AF is a big risk factor for bad outcomes, both strokes and deaths. So what causes AF actually? And there's a number of risk factors. And the biggest one of them is age, as you can see. But a lot of other things also lead to an increased risk of AF. Things like heart failure, abnormal heart valves, hypertension, high blood pressure, diabetes, obesity, and things that people may not know so much about, which is alcohol and sleep apnea. And finally, there's also a group of patients who get AF from a family history. What this does is that it increases the pressure, increases the amount of stretch in your atrium, the chambers that have AF, and also it leads to abnormal electrical activity in the heart as well. Over time, this leads to scarring or fibrosis, as we call it, and an abnormal electrical properties of the heart, which is what sustains atrial fibrillation. One of the ways we've studied AF is to do goat models of AF, right? So up the top, you see normal hearts from goats. In the middle two panels, these are goats that were given atrial fibrillation by pacing their atrium very fast. This is a classic model of giving goats AF. In fact, it was the first model that was developed. And what you see is that when you look at the blue areas, you see that there's not that much blue, but when you test the heart muscle, its electrical properties are abnormal. So you can do that, so you can give AF by changing the electrical properties of the heart. Or the bottom one, which is goats that have been given heart failure, and there's various ways to do that, you see all the blue turn up, and that's scar tissue. And that's another way to get AF, and these goats also get a lot of AF when you do that. What about in humans? So this is human tissue, okay? On the left-hand column, left-hand side, that's all normal hearts. On the right side is AF hearts. And in this one, the stain used is different, and fibrous tissue shows up as red. And you can see clearly that normal hearts from different parts of the heart have much less red than AF hearts. And that's because there's less scar tissue in these ones. So the obvious question is, okay, you know what the risk factors are. What can you do about that? Of these risk factors, two of them you can't do anything about, right? Age and family history. There's nothing you can do about that. The rest, you can do something about that. These are actually very big topics. So heart failure, valve disorders, hypertension, diabetes, obesity. I think we all know about that. I wanted to concentrate on two topics that maybe there's less knowledge about, okay? Alcohol and sleep apnea. And alcohol is a big deal. So this is Korean study, and we know how Koreans drink. This is from, again, this is based on the national data. And I'll just look at so the blue line is men, and the red line is for women. And if you look down the bottom, right at the left is people who drink no alcohol. That's 0. And so they're used as a reference group, so their risk is 1. And you go 10, 20, 30, okay? Right at the end is 30 drinks per month. That is 1 drink per day, okay? That's not a lot. Even then, you'll see that in women, it roughly doubles your risk. Even 1 drink a day, 1 standard drink a day. For men, it's 14 to 15 times higher. I think the reason it's high is because I think Korean men aren't honest about how much they drink. I have a Korean patient. He is always very good in Singapore. Every time he goes back to Korea, he comes back with AF. And that's because he meets his friends, they go out drinking, and he comes back to the clinic in AF every time he does that. But when he's in Singapore, it's very good. So during COVID times, he was very good. He was in normal rhythm most of the time. So any drinking at all would at least double your risk of getting AF. Interestingly, binge drinking, which is what my Korean friends do, is that they will drink nothing for a while, and then on the weekend they'll have 15, 20 drinks. And that's even worse for you. That actually triples your risk. And overall, binge drinking is bad. Okay, if you're gonna drink small amounts regularly, that's fine. But binge drinking is worse. It's worse for your liver, it's worse for your heart. So not something you want to do. So only one solution. You either reduce or abstain. There's nothing else you can do about that, okay? And the solution is quite easy. The other thing that people don't think about often for AF is sleep apnea. So what is sleep apnea? Sleep apnea is basically disordered breathing during sleep. And the typical things that people get is very loud snoring and excessive sleepiness in the daytime. And I'm sure someone in this room has sleep apnea because it is extremely common. It's probably far more common in East Asian populations because we think it's because of our jaw shape and size. We're more likely to develop that. So when we sleep and lie back, our airway obstructs and we stop breathing. So you might know people who snore very, very loudly and the snoring suddenly stops. And then you hear nothing for a while and they go, and then they wake up again and then they start breathing again, right? They don't completely wake. It's like a microscopic vaping thing. And they don't completely wake up, they don't completely sleep. So these people have very, very poor quality sleep. Interestingly, it's strongly associated with obesity, with hypertension, and diabetes. And they all often coexist. Many people have it, but never get it checked. Part of the reason is it's a little bit tricky to check because you have to go for a sleep study, you have to wear this device that measures your oxygen levels, et cetera, and it's a bit of a hassle. And more importantly, people often don't think about that. The only treatment for this, well, one of the best treatments for this is actually wearing a CPAP machine. I'm not sure whether you have seen this before, but it's basically a device that you wear over your mouth or your nose. There's a newer mask designs, like this one is one of the newer mask designs where it's only just the nose. And it increases the pressure in your airway and keeps your airway open so you breathe through the night. You might think, oh, this is terrible, I'll never be able to sleep like this. Some patients, when they put this on, they have the best sleep of their lives, okay? And they feel so much better, they'll put up with this. I have patients who bring this on their holidays because they can't sleep without it anymore, yeah? Because they realize it's such a difference to your sleep quality. So it is very useful, and we regularly screen our AF patients for sleep apnea. And who knows this? Who knows who this is? No, it's Joe Biden. Joe Biden. Joe Biden, and you can see on his face there are band marks. That's because he has sleep apnea and he uses CPAP, and he also has AF. All right, so he's a classic example of someone who has AF and sleep apnea, and clearly he uses it all the time. It's a good thing. Okay, so what do you do if you have atrial fibrillation? There's basically a few things that you need to do. First of all, you need to reduce your risk of stroke. And for this, the mainstay is to use a blood thinner. Blood thinners used to be warfarin. Everyone's familiar with warfarin, right? But there's now newer drugs. They're not that new. They've been around for 10 years. They used to be called novel oral anticoagulants, but they're not that novel anymore, so we call them non-vitamin K antagonists oral anticoagulants, which is a real mouthful. So we just call them NOACs. All right. So these NOACs include the Pixaban, Rivaroxaban, the Bigatran, and the Doxaban. The Doxaban's just released in the market. I don't think it's used very widely. The other three are far more commonly used. The other thing that's very important is to try and restore normal heart rhythm if possible. And this is usually done with drugs to start with to abolish the AF, but many of these drugs are not very effective. And some patients might need an ablation procedure. I won't go into that, that's another big topic. But basically we are, since maybe about 2-3 years ago after a publication of a very important paper, we are far more aggressive in trying to restore sinus rhythm for patients with AF. And that's probably something you'll see more and more. And finally, in patients who have AF that you cannot get rid of, we just control the heart rate as best as we can. Because even if we can't restore normal heart rhythm, as long as your rate is not racing away like 150 beats per minute, you can lead a fairly normal life. So I'm going to talk a little bit more about stroke prevention because that's one of the key things about AF treatment. We have this thing called the CHAS-VAS score. Maybe you want to tote up your score as we talk along about it. So this is a score system to tell you what's your risk of stroke if you have AF, all right? So if you have a previous stroke or a TIA, like a mini stroke or some other blood clot fly off in your circulation, that's 2 points. If you're over 75, that's 2 points. If you have a history of congestive heart failure, that's 1 point. If you have hypertension, it's 1 point. Diabetes is 1 point. If you're between 65 to 74, it's 1 point. So over 75 is 2 points, but 65 to 74 is 1 point. If you are female and you have any other risk factor, you also get an extra point for being female. And finally, vascular diseases, if you've had a history of heart disease, like heart attacks, or you had peripheral vascular disease, like blocked arteries in your legs, that's also an extra point, okay? So if you are lucky and your point score is 0, your risk of stroke is very low. It's 0.78%, right, on the left-hand side. It's actually a very low risk. But once you get up to 1, your risk is 2% per year, I should add. This is per year. If you've got like 4 or 5, like let's say you're 75 years old or older, so it's 2 points, you got hypertension, diabetes, you have 4 points. Quite common. Your risk of stroke is 9% per year, all right? So it's roughly double the score. You have one more risk factor if you're female or something like that, or if you have a history of heart failure and your score is 5 or 6, it's roughly triple your score. So if your score is 6, it's 19%, okay? So it really ramps up very quickly once you have high risk. So surely anyone with high risk would all be on a blood thinner, right? You would think that we would be very good at that. But no, because blood thinners have had a very bad reputation. You'll find that we've been using warfarin. Warfarin is actually the trade name for a brand of rat poison. We used to give this to rats, and the rats will eat this. They'll go back to their burrow, their mouse hole, and then they'll bleed to death. Okay, so this is why a lot of people don't like that. And you can see it from data. This is data from earlier in the last decade. So we did this. This is a Garfield study that we were involved in. So on the left-hand side is Singapore, on the right-hand side is the world population. This is a big study, 56,000 patients. It's very colorful, but I just want you to look at one thing. So down the bottom of each column is the risk score. So if your risk score of 0 is right on the left side, and the risk score of 6 to 9 is the second one on the right. Okay, so these are 6 to 9 means your risk of stroke is approaching 20+% per year. Okay, the colors mean, just bear with me with the colors. So blue are patients on warfarin. The red orange thing are patients on the NOACs. So these are the ones who are appropriately treated. And you see that the rates are extremely low, 40, 60%, right? Very low rates in the whole population. The green are patients on antiplatelets, so aspirin, Plavix, or clopidogrel, ticagrelor, those kind of drugs. That's not appropriate. We don't recommend using antiplatelets to treat AF because it's not effective for reducing stroke. And the worst thing is the purple up the top. Those are patients who are not on anything at all. And if you look, even patients with very high risk scores, like 5 or 6 to 9, these are 15, 20% per year stroke risk. There's still like 10, 20% of them who are not on anything. Okay, this is terrible. And I think this study was started as the NOACs became available. It was very interesting. The next table will show you why it's interesting. So you say, okay, so more and more people take NOACs. Wouldn't we have more and more problems with people bleeding to death and all that? So this is from Taiwan, from Zhao Zifan's group in Veterans General. Professor Zhao has done a lot of very interesting work in this. What he's found is, okay, so bear with me. So on the left-hand side is 2008, and all the yellow is warfarin only. In 2012 in Taiwan, the NOACs became available. First was the Bigatrand, then Rivaroxaban, and the Pixaban. And from 2012, overall rates of anticoagulation went up. Blood thinner use was increased. And that's mainly because more and more people went on NOACs, and fewer and fewer people stayed on warfarin. And the very interesting here is a very complicated graph, but just what they found was that because more people on blood thinners, fewer people had strokes, fewer people had deaths, and fewer AF patients actually had bleeding. That's because the new NOACs are safer than warfarin in terms of bleeding risk. And so, no-brainer, you really need to use this. But you should also note that even in 2015, in spite of all this, only 60% of eligible patients with AF were on anticoagulation of some sort in Taiwan. And this is in a public health system. So it is still an issue, and it's an ongoing issue, and we'll also talk about that. So I have AF, let's say you have AF now, and I'm sure some people in the audience has that. Should you take a blood thinner? I think the first thing you need to do is consult your doctor to determine what's your risk and figure out whether you should be on it or not. Most patients probably should start on a NOAC of some sort. I think warfarin is now mainly reserved for patients who have a reason to be on warfarin, say if you've got a mechanical heart valve or you've got mitral stenosis, a particular kind of heart valve disorder, then yes, you still need to be on warfarin, but otherwise pretty much everyone should be on a NOAC. And once started, don't stop it unnecessarily. Always ask your doctor. I never stop it for tooth extractions in my patients. I never stop it for minor stuff. I don't even stop it when I put a pacemaker in. It's quite safe to do a lot of procedures on NOACs. You just don't bleed badly enough. Okay? And the thing that I always get asked is, I take this blood thinner, but I don't feel a thing, and nothing's happening. Well, all I can say is, that's great. That's exactly what's supposed to happen, which is absolutely nothing. Because if nothing happens, it means that you've not had a stroke. And it's very hard to convince patients about that when nothing happens, right? When you take a blood pressure pill, you see your blood pressure come down. Take a cholesterol pill, you see your cholesterol come down. There's something that tells you it's working. But with blood thinners, nothing happens. And that's precisely what it's meant to do. Okay? So don't be too worried if you feel like nothing's happening. Of course, everyone's worrying about bleeding. What do? You consult your doctor or you go to emergency. That's basically it. Most of the time, it's nuisance bleeding, like you cut yourself and you bleed. You just press on it, it always stops. Tooth extractions, you just press on it, it will always stop, okay? If it doesn't stop, then maybe there's a problem, then you need to go to see your dentist again or go to emergency, but almost always, it always stops. The only thing, of course, is if there's a serious emergency, like accidents and things like that. But even that, we have ways to deal with that. And so finally, I always say, follow the science. The science says that AF patients should be on anticoagulation. And there's plenty of science around. So this is, I mentioned Prof. Zhao Zifan. He leads this focus update that talks about stroke risk and how we should manage that. And I was very fortunate to be a co-author on that. And there's a lot of guidelines out, and they're quite clear that everyone who qualifies for NOAC should be on, with AF, should be on a blood thinner of some sort. So my first summary is that AF is a major public health challenge. It's an aging population. It's going to get increasingly prevalent, and more people are going to start having strokes and problems. Aging is a major factor for this, but there are also other risk factors you can do something about that. So control your risk factors: hypertension, diabetes, obesity, exercise regularly. If you have sleep apnea, get it treated. If you drink too much, cut it out. Basically, that's it. And finally, always consult your doctor, yeah? Okay, so that is about half an hour. In the next few minutes, maybe I'll talk about a little bit of what we've been trying to do for AF patients. As I mentioned, a lot of AF patients don't get treated appropriately, and we do something called integrated chronic care for AF. Basically, Singapore is a very hospital-based clinic, kind of. If you have AF, you always go to a hospital clinic, you see a doctor, and it's always been like that. But there's actually problems with that model. First of all, it's unaffordable in the future. We cannot do that anymore, which is why we've got Healthy SG happening. But there's also a lot of other issues with that. And we probably should be approaching it with a technology-enhanced service and also using more allied health workers for that. And this is actually recommended. This is the European Society of Cardiology AF treatment guidelines. And you'll see that integrated AF management is now part of the guidelines. In other words, it should be done for everyone. And there's a lot of aspects to that. So other than optimized stroke protection and controlling the symptoms and all that, there's a big element of patient education and self-management. Patients need to look after themselves because chronic diseases are not treated by doctors, they are treated by the patients, right? You're the one who exercise, you're the one who take your pills, you're the one who eat the healthy food. We can't do that for you. So patient education, lifestyle modification is very, very important. There's also other issues like psychosocial management is mentioned there. But more importantly, there's also things like strategies to promote health medication adherence so people stay on the drugs that they're prescribed. And also using a multidisciplinary approach, which is basically a team of different health professionals to help you with that. Okay. So where did this come from? This actually started with this paper. This is from Maastricht in the Netherlands. And it was done by a friend of mine, Jeroen Hendricks. And he's a nurse. And what he did was he ran a nurse clinic next to Dr. Thielemann, his cardiologist, who was his PhD supervisor. He was in the next room to him. And Jeroen basically followed a very strict protocol. If you have AF, you have these risk factors, you get this treatment, et cetera, et cetera. If he had any issues or he's not sure, he'll open the door, go next door to ask Dr. Thielemann, what should I do with this guy? The surprising thing is, his patients did better. His patients had better adherence to guidelines. They had fewer deaths and fewer hospitalizations, which is pretty remarkable. Okay, this is a landmark paper, and in fact, Jeroen is the lead author in the ESC guidelines for integrated care. So can we do this in Singapore? We thought about doing it, but we wanted to take it a little bit further. We wanted to do it in Singapore, but we wanted to do it in primary care, in the community. And it's all about what we call patient-centric care, getting patients to learn more and manage themselves a bit bit better, and also as a result of that, we think we can improve patient compliance. And this is how this clinic runs. So AF patient comes to your primary care doctor. This is currently running in Bukit Batok Polyclinic. We're going to replicate in other polyclinics as well. They see a primary care doctor, and in the old days, what did they do? They refer you off to a hospital, right? But they don't do that. No, these specially trained polyclinic doctors are allowed to order echo scans, like ultrasound scans for the heart, Holter studies, which are ECG studies for your heart, stress ECGs, etc. They can order it themselves. The patient goes to the hospital and gets these tests done, then comes back to the primary care doctor for a team review, the other team member being a nurse, advanced practice nurse practitioner. They will then decide whether these patients can stay in primary care. If they don't have anything seriously wrong on all those tests, then they will stay in the nurse-led integrated chronic care clinic. If not, we used to have these monthly cardiology clinics. I used to go down there and see these patients with them. I've stopped doing it because they don't need it. They're fine. Okay. But once in a while they get too difficult, then these patients then get referred to the hospital. But if not, then I will send them back to the nurse-led clinic. More often these days is they will text me. They'll text me or send me the report and ask me, hey, look at the echo report. Can this patient stay here? Or they have an ECG they don't understand. They'll text me and I'll just reply, say, hey, this is fine. You can do this, this, and that. And they carry on with that. And so this clinic is actually running still. And it was featured on the news recently. That is Wei Feng, one of our advanced practice nurses with a patient. And basically, the advantage of the nurse-led clinic is they have a lot more time for the patients. They have a lot more patients experience. Wei Feng is an exceptional nurse as well. She's been leading the way with this and has a great relationship with the patients. The other thing we did was we have a website on the left hand, you see on the right hand side, that's just scrolling through on a phone. I'll give you the QR code for that later. And it basically goes through what atrial fibrillation is about. The website is available in English and Chinese. Was built by one of my PhD students who studied this for her PhD, and has been very, very helpful. You saw that there's a Chinese version as well. And so it's all about patient education, patient management, and patient empowerment. This is our team. Jiawei, the guy seated, Jiawei is the family physician in this clinic. There's a few of them now, but he was one of them. And basically, it is a protocolized follow-up. They go through a fixed program. If they are suitable for that, then they stay within the clinic. If they're not, then they go to a specialist clinic. But sometimes I send them back as well, okay? And so the idea is to make sure that the patients stay in the clinic, they get to know the team very well, and they get all their comorbid conditions, because this is the polyclinic, right? So they get their diabetes checked there, their blood pressure checked there, they get everything else sorted out there as well. And if they have a rash, they can ask Jiawei, because I have no idea about rashes. My patients come to me and say, oh, what's this rash? I have no idea anymore. So the family physicians are far better at that. And what we found is that it is safe and effective to do this in primary care. Patients are very appreciative of the high quality of patient education and counseling by the nurses. They feel that, we've done studies on this, and they feel that the care is more personalized with a consistent team of healthcare providers managing them. And of course, it's convenience of having all your chronic conditions managed as well by this doctor. So in summary, AF patients, I think, should and can be managed in the community. I think modification of risk factors really should be part of AF, as I mentioned. All these risk factors, hypertension, diabetes, obesity, these are all risk factors for AF. Even if you already have AF, improving those actually controls the symptoms and reduces your rates of AF. So that's very, very important as well. And finally, I think patient management and self-management, patient education and self-management is really key to all this. And I think that's my last slide. So here's the QR code. You can scan that. That will take you to the website. Thank you for your attention. Thank you.
Thank you, Dr. Lim. Thanks for the informative sharing. So right now, we will move on to the Q&A segment. If you have any questions for Dr. Lim, please raise your hand and I will go over to you with the mic. Okay.
Doctor, you talked about people with AF what about if it is intermittent or what they call paroxysmal AF? Do they need this tardiness? If it is not that serious, it comes and goes maybe once a week or something in that order.
Yes, that's a very good question. Patients with, so there's basically three types of AF we talk about, but this is about how often you get it. There's paroxysmal AF, persistent AF, persistent AF being episodes that last longer than 7 days, and long-standing persistent is more than 1 year. Paroxysmal AF are patients who get minutes to hours of it, basically all these patients have an increased risk of stroke, and so we treat them exactly the same. If you go from paroxysmal, which is intermittent AF, to persistent AF, your risk does go up more. But even at the level of intermittent or paroxysmal AF, you also have a risk of atrial fibrillation. What about the ones who you get it on your watch, right? Your watch always tells you got AF. The definition of AF now requires an ECG. You must have a proper ECG done, or at least you need a 30-second ECG strip from your watch to be interpreted by a doctor to qualify as being AF. When we see that, even though you are intermittent and you feel like you only have a few minutes, you are actually already down the path of developing more and more serious AF. If we threw ECG monitor on a whole lot of people, and we know this because we are patients with pacemakers, a lot of people get like a few seconds of AF all the time. But if you have a few seconds, it doesn't seem to increase your risk of stroke. But by the time you have enough of it that you can catch it on your watch, catch it on ECG in the clinic, you probably already have a lot of AF and your risk is already high. So yes, we treat them all the same.
For patients with a murmur before, will it end up to have AF?
Okay, so it depends on what kind of murmur it is. So a murmur is basically where blood flow through your heart is turbulent and causes you to hear noise, right? So that's a murmur. If you go up to any pregnant woman in the last trimester, they all have a murmur. Okay, that's because the heart's pumping very fast. Go down to the sports field, any young person running around will have a murmur because that's because of blood flowing. So murmur doesn't mean that there's something wrong with your heart. It really depends on what's the valve that's affected and how it's affected and how serious it is. Having said that, as I mentioned, valve disorders is a common cause of AF, right? And the AF that we find with valve disorders, especially with mitral valve disorders, is particularly bad, especially if you have something called mitral stenosis, where your valve is stiffened and doesn't open properly. Those patients are particularly high risk. Rheumatic heart disease used to be much more common in Singapore, but it's quite rare now. Remember, I mentioned 5 times increased risk of stroke if you have AF. If you have rheumatic heart disease and AF, your risk of stroke is 17 to 20 times higher than the population. So it's a higher risk group, and we treat them. So those ones can't be managed in primary care. Those ones we have to see a specialist. They're much more tricky.
So does a murmur need to be treated?
Not necessarily. So murmurs are very common, and even if your heart valve is abnormal and not functioning, not closing properly, not opening properly, the treatment for murmurs these days is open heart surgery, or something where it involves putting this huge tube through your artery and implant a valve in your heart. High-risk procedures that they are not simple things to do. So we only treat it when it reaches the point of being severe. So moderate, mild, we don't treat yet because the risk is not worth it. So we only wait till you have much higher risk, then we will treat that.
Thank you.
So since he's talking about murmur, how about MVP?
Okay, very good question. MVP is extremely, so there's a question about what about mitral valve prolapse. Mitral valve prolapse is very common. The good thing about that, though, is that very few people with MVP progress to have severe mitral valve dysfunction. It's much less than a couple of percentage points. If you had MVP all your life and you're still fine, you're probably going to be fine. Okay. But MVP in itself, yes, if you've got very severe mitral valve dysfunction, does increase your risk of AF. And again, we will treat it if the mitral valve is functioning very badly. Otherwise, we leave it alone.
In spite of my medication, my BP every time goes very high, and I feel breathless, and I have a lot of fibrillation. How come?
Okay. So palpitations and breathlessness are the two most common symptoms of AF. So if your AF is not well controlled, then that would be something that you'll have all the time and often. The high blood pressure could be two possible reasons. One is you actually have high blood pressure and you need to take a higher dose of your antihypertensives. Or secondly, that's very common in my patients with palpitations, is that it's very stressful. I'm not sure who has experienced palpitations in this room, but if you've had palpitations, you'll know what it's like. It's really stressful. It's very nerve-wracking. I've had palpitations before as well because I had a lot of extra beats after I got COVID. It's a very common thing again after COVID. And it's unpleasant, and patients suffer greatly from that. And when you're very stressed, your blood pressure goes up. So actually it may not necessarily be that you have hypertension, but it could be the stress. So what do? We have to treat your AF better and get the symptoms under better control, and that's usually the main thing to do.
Maybe Dr. Lim, a question from myself.
Okay.
Will COVID actually increase the chances of AF?
COVID is a funny virus, isn't it? So those of you who know that there's a lot of, when COVID first came out, there was a lot of myocarditis. We estimated in the alpha wave that maybe 10%, 20% had inflammation of the heart called myocarditis. Some people got very, very sick. You might have heard about the people who got put on ECMO, which is extracorporeal membrane oxygenation. Basically, a heart-lung bypass machine. In fact, one of my friends ended up on ECMO. And it can be very severely damaging to the heart. And those patients are increased risk of AF in later life. On the other hand, there's also a lot of people who had mild symptoms like palpitations, like ectopic beats. These are extra beats that fire off intermittently. I had quite a lot for about, I think, 4 to 6 weeks. A lot of my friends who got COVID also remembered having that. So doctors are very good at that. They know exactly what it is, so they can put a finger on it. But I think a lot of the population also felt like the heart was going crazy after COVID, right? And they didn't know why. Most of the time that settles down. Does it increase your risk of AF later on? We don't know yet. So we'll find out, maybe in 10, 20 years. But we don't know yet. But certainly COVID was a virus that affects the heart quite a lot, which also explains why the vaccine also had some side effects that affected the heart as well. And so it's rare. It's very, very rare. We probably have, I think, only one confirmed death from it. It is not uncommon. I do see quite a lot of patients with that because of the practice that I do. But it is still very rare. Incidentally, it actually happens with other vaccines as well. It's just that with COVID vaccine, because the whole population suddenly got it, there was a lot of cases. But it actually happens with other vaccines as well. But it's just that it's very rare and it's very intermittent.
Thank you.
Dr. Wish asked you, I started a palpitation on for many years, but couldn't actually catch a AF. But recently, I was caught an ECG and also on my watch. So was started on treatment, anticoagulant and also this Prisopolo. To start with the Prisopolo, my blood pressure used to be on the lowish side. It's 100, 110, 70. So with the Prisopolo, it actually dips further. So I'm feeling a bit tired and very off, right? At the same time, I become a little breathless. So I was told to consider ablation. But then again, I didn't want anything that is invasive. But then Having said that, I started the medication for a month, coming to a month, and it continued to have this atrial fibrillation, though the heartbeat actually came down to 70, 80s. But the rhythm is never regular. What should I consider? I mean, the Bristol Polo is also taking a toll on my daily life.
Yeah.
Thank you.
So with atrial fibrillation, it's about choosing the side effect you want to live with. All the drugs have side effects, and it affects some people more than most. Bisoprolol is mainly people feel fatigued, tired, and some people feel frankly depressed on it. But with other drugs, you have other side effects. There's the other alternatives like verapamil or diltiazem. You end up getting constipated, which for some people is worse than being depressed. So the thing is, it sounds like that your doctor is aiming for rate control rather than rhythm control. I mentioned that just then about whether you restore normal rhythm or you just try and control the rate of the AF. And up till 3-4 years ago, it was not clear whether one was better than the other. It was only in 2021 that the EastNet AF study was published, that it became clear that rhythm control is probably preferable for newly diagnosed patients. And in that study, most patients started with drug therapy and not bisoprolol. Bisoprolol is not considered a rhythm control drug, although it has about 10% effectiveness of reverting you back to normal rhythm. It's very modest. We're talking about drugs like flecainide, propafenone, dronedarone, amiodarone, drugs like that, which again have more and more side effects, but their effectiveness is much higher, between 40 to 60%, and still not 100%, only 40 to 60%. But if you can get people into normal rhythm to start with, you can often stay in that for many years. But ultimately, you have to consider if you lose control. So over the years, what happens with AF patients is that the drugs you get treated on will fail. And when that happens, in the old days, we used to wait for patients to fail 3 or 4 different drugs before we ablate. I think it's much less now. I think I would normally now give one drug, just like in the clinical trial I mentioned, the EastNet AF. If that doesn't work, then I would recommend ablation already. Because the idea is, I mentioned about the altered electrical properties of the heart when you have AF. In the original goat studies, this is like from the 60s, 50s and 60s. What they found was that once the goats started having AF, the more AF they have, the quicker they get AF again over time. So there's this term that they coined, the group coined, AF begets AF. So the more AF you have, the more AF you will have later on, because AF itself is damaging your heart. So the thinking now is that we should treat early with drugs, and if that fails, quickly think about ablation before more damage is done. Yeah. So ablation is certainly something that is now mainstream.
This cardioconversion.
Cardioversion, okay. Cardioversion.
What do you think of that?
Okay, so cardioversion is where we put you to sleep and we put pedals on you, like in the movies, right, in ER, and then you shock them and then it resets your heart and puts you back to normal rhythm. We would do this if you're intermittent AF, then obviously you don't need that, right, because it'll go back by itself. But if you're persistent AF and you're in it for days or months, it can restore you back to the normal rhythm, and you could be in it for days, weeks, or even months. But eventually, you will go back to AF again. So if you did cardioversion on 100 people with AF, after a year, only 30 to 40 will still be normal rhythm. Most patients will actually go back to AF. Why do we still do that? Is because if you've got persistent AF, what I do is I will do a cardioversion for you. If I cardiovert you, you go back to normal rhythm, and then within minutes you're back to AF again, then there's no point trying to ablate. The ablation success rates are very, very low. So that's the reason we use it. If I cardiovert you and you go back to normal rhythm, here's the other thing. If you go back to normal rhythm and you can stay in it for months, so first of all, your success rates are higher. And secondly, it gives you a chance to figure out how AF is affecting you. because my patients will go home in sinus rhythm and they'll feel $1 million. And they'll come back to me a month later and say, Doc, I feel so much better. Can you please do the ablation? Okay, so that's the other thing. And also, of course, the other side also, the other scenario also happens. I have patients who go back, come back to me a month later in normal rhythm and say, Doc, I don't feel any different at all. You know, in that case, then I say, okay, then maybe you don't really want to have the ablation then. So that actually has an impact on how I manage patients. So it still has a place to. There are patients who refuse to have ablation and come in every few months for a cardioversion. It's a bit stressful, but they prefer to do that than to have an invasive procedure. So that's fair enough too.
My question is actually very basic. Does AF affect the sleep pattern?
Okay. Some patients actually feel the palpitation so badly that it affects the sleep.
You do know. Will you know it? Will you feel it?
Some patients do feel it in their sleep. They wake up with AF. They feel their heart racing and it wakes them up. So it's possible, yeah. But if you're finding that your sleep is disturbed, you really need to be checked for sleep apnea. It may be the other way around. It's your disturbed sleep that's causing your AF. There's a very famous study that they did in Adelaide, where in Adelaide, the waiting list at the Royal Adelaide Hospital for an AF ablation is 1 year. So if you decide to have it, you have to wait a year for your turn. In that 1 year, they send all their patients to a clinic where they screen them for sleep apnea, get them to lose weight, change their diet, get them see a physio, see a dietitian. And most patients lose 10% of their weight. If they have sleep apnea, they get treated with that. And half the patients come off the waiting list because they feel so much better. And the AF is so much better controlled because they've got all the risk factors controlled. So that's also very important to take note of. And so yeah, so have yourself screened for sleep apnea. Go talk to your doctor.
Can I ask you another basic question? If a guy exercises regularly, he's not overweight, he's not suffering on diabetes, hypertension, can he still suffer on the AF?
Yes. So the question is, if you do all the right things and you exercise regularly, can you still get AF? There is this entity called lone AF. This is lone, L-O-N-E. So patients who have nothing. I have some 40-year-olds, 50-year-olds with that. Sometimes it's a family history, but often there is no family history. And these ones, we don't know why they get AF. They have no hypertension, no diabetes. We screen them for sleep apnea. They are completely clean. They're often very, very active and fit as well. So yes, you can get it without it because there's one thing that you cannot change, and that's age. Right? Age is a big risk factor. It's wear and tear of the heart. But with regards to exercise, there is the other flip side of exercise. If you exercise excessively, you can also get AF more. By excessive, I mean elite athletes. So there's a very famous ski race in Sweden. It's like an 80-kilometer ski race. You have to ski for 80 kilometers. And what they did was they looked at your finishing times. And the people in the fastest finishes, the fittest, craziest skiers, had higher rates of AF on follow-up over like 10, 20 years than the ones who were the slowest. So the more elite an athlete you are, the more likely you are to have AF. So on my follow-up, I have an AF patient who used to be a national cyclist. I have another elderly man. He's like in his 70s. He stopped running now, but when I first saw him, he was in his 60s and 70s, was running half marathons for fun. He would run 20 kilometers for fun. So elite, he was elite level for his age, and he had a lot of AF. I told him, you have to stop running. His AF got a lot better. Well, actually, I ablated him first, then I told him to stop running, and his AF basically went away. So now he just brisk walks. So if you do overdo it with exercise, it does increase your risk of AF, but really at the really elite levels.
We'll take one last question.
So if someone, let's follow through. If someone who used to be very, very active when they are young, actually,
yeah, so
for example, I used to be very, very active in sport until the age of 35, then career catch up with me, I slowed down.
Yeah, so
Will it affect me now that I'm
We don't know for sure, but based on the skiing study, probably. But yes, at the elite levels there has to be pre-elite levels. All the ones I've seen are all elite sportsmen, national levels, state level. There's a state level badminton player I have on my follow-up. So yeah. Last question?
Dr. Lim, what do you think of this Xarelto as a blood thinner for people with parallel AF?
With
People with AF.
okay. Are we allowed to say trade names here? Okay. Xarelto is otherwise known as the rivaroxaban. There's arguments back and forth about which one's better, which one's worse. You can pick any number of studies to say which one's better, which one's worse. I think between the NOACs is very hard to tell because the clinical trials that we get our information from were designed differently. What they all are is that they're all superior to warfarin. And the difference might come down to whether you want a once daily drug or a twice daily drug, what your kidney function is doing. There's a lot of considerations for that, and usually the doctors will pick the drug based on all these considerations. Yeah, it's a good drug. I mean, it's been shown in large clinical trials to be effective for stroke prevention and better than warfarin. So yes, if you're on it, then you should take it.
Can I display your last slide before this one?
Oh,
Thanks.
yeah.
Okay, thank you, Dr. Lim, for answering the questions.
Thank you.
So, of course, before we end, I would also like to invite Dr. Lim once more to share a closing remark. So, Dr. Lim, what would be the most important thing you would like the participants to take away from today?
Not knowing is not good enough. I think you need to know whether you have AF or not. And the solution is very simple. Beyond a certain age, and I'm looking in this room, I think we are all beyond that certain age, by which I mean 40, you really need to be regularly checked. And that would include getting your ECG done, getting your blood pressure checked. That's the whole point of healthy SG, right? So that's basically it. Not knowing is not good enough. Just get yourself checked. Thank you.
Thank you. Thank you, Dr.